Custom-tailored prostate cancer treatment at Radiosurgery New York.
Welcome back to the Radiosurgery Hour. This is Rob Redstone here with Dr. Gil Lederman at the WOR Studios in the heart of New York City. We're just a few steps from the Radiosurgery New York Cancer Treatment Center on Broadway and 38th Street. Dr. Lederman, the leading cancer expert, treats prostate cancer non-invasively. He was the first in New York with fractionated brain radiosurgery, and he's the first in America and in the Western Hemisphere with body radiosurgery. You can also call Dr. Lederman at 212-CHOICES for a free informative booklet and DVD. Hey, Dr. Lederman, we're back.
We're back. Rob, how you doing there?
Doing well.
All right, so hopefully we'll get to that street fair about health in the Spanish community. If others out there have other announcements about health care, cancer, we'd be happy to help and happy to bring our staff to provide information in your language or information even in English. So there's a new study out looking at the best treatment for people with gastric cancer that has metastasized.
Okay.
And often, once cancer is metastatic, the chemo doctors often give chemo, and sometimes we don't remember there's other methods of treatment that may be better.
Absolutely.
And the study actually looked at SEER data, S-E-E-R. Do you know what SEER data is?
No, never heard of it.
SEER data has been collected over decades. And some states, I believe like Connecticut, the entire state reports all their cancer data to a central registry.
Okay.
And certain cities across America, like New York and Boston and Los Angeles, report all their data. And so they have a huge mass of data. And then you can compare data. Let's say, for example, you find 6 of your medical school colleagues who have cancer. Mm-hmm. And you want to know, is that a normal number in this group of people, or is it an abnormal number? So you can actually go to the SEER data and find age-matched sample. You can find whatever, 5,000 people, and then look at the cancer rate for 30-year-olds and see, is it, a normal population? Is it 0.2% or 2% or 20%? And see if there's some contamination. Like these people that say, I live in Long Island and there's an excess of breast cancer in Long Island, because everyone they know has breast cancer. Well, is that number true or not true? And so SEER data is used for that kind of study. And I've used it in some of my studies where we've shown that standard radiation can actually cause heart damage. So I've been using SEER data for 25 years. So anyway, these investigators looked at, from Moffitt Cancer Center, looked at people with gastric cancer that was stage 4, which means it had metastasized somewhere.
Right.
And they looked at survival if the patient had chemo and radiation, or chemo, radiation, and surgery. And they actually found that the survival was better in patients who had all 3 modalities. They looked at 5,000 people, and they removed people that lived less than 3 months. So left over were 3,000 people who had neither surgery nor radiation. They had 800 people who had radiation alone, 900 people who had surgery alone, and 240 who had both surgery and radiation. Mm-hmm. And there were differences in the groups. The median survival and 2-year survival was 16 months, and the 2-year survival was 31% if you had surgery and radiation.
Okay.
If you had surgery alone, it was almost half that.
Okay.
So the radiation seemed to have doubled the survival. Went from 18% in surgery only to 31.2% in surgery plus radiation.
Right.
And if you had no surgery, no radiation, the survival was 7 months.
Wow.
And there was Kaplan-Meier analysis. Have you studied what Kaplan-Meier's curves are and what their analysis?
I've seen them. I'm not sure exactly.
Yeah, Kaplan-Meier they also tried, in medicine, you try to find out if one group is truly different from another group. If 5 of your short neighbors and 10 of your tall neighbors have, halitosis, is that really a difference? And you have to look at the numerator, the denominator, and compare the groups, and there's statistical ways to compare it. And that's what Kaplan-Meier is about, comparing different groups. So they did Kaplan-Meier analysis of these 3 different groups and found that it was true that there were survival benefits for the group that had radiation and surgery. So it's not usual. Most people with gastric cancer don't get surgery and don't get radiation. And the whole point of this study and the whole point of talking about it today is for those out there who have gastric cancer, which is cancer of the stomach, or who have loved ones or neighbors with it, that you may want to think about other methods of treatment. And I just finished a patient, also a Hispanic man, who had gastric cancer. He had attempted surgery, and they could not remove the stomach cancer with surgery. He had a liver metastasis, and his surgeon sent him to us for treatment. So we used radiosurgery for the liver metastasis.
Okay.
And chemoradiosurgery for the gastric cancer.
Mm-hmm.
He had follow-up PET scan, which is a way of looking at the cancer in the body. The PET scan showed the liver totally went away.
Okay, great.
Totally went away. Liver metastasis totally went away, and the gastric cancer in remission. So I'm sending him back to the surgeon now because we know that people who have trimodality therapy are going to have a better success rate. But he's in remission, like we talked about before. He's in remission, but we don't know that he's cured. I mean, cure will take until he dies of something else, but he's in remission from combined modality therapy.
It's fantastic. And gastric cancer is also a very tricky type of cancer to treat, right?
Well, tell me why.
Well, generally, I know that it's recognized very late.
Why?
Like other cancers. I guess because the signs are just usually not there until it's already advanced, right?
Right. So the stomach is deep inside the body. You can't feel it. Sometimes people have vague symptoms where they have bleeding.
Right.
So maybe they'll have what's called black tarry stools.
That's right.
So the bowel movements change from a normal color to like road tar.
Yeah.
And that road tar is a sign of?
Bleed.
Yeah, it's bleed. It's actually the blood digested by the gastric juices. So if you have a rectal cancer and bleeding, usually the cancer causes red blood because it's so close to the anus, which is where the blood comes out. But gastric cancer is exposed to all the juices of the stomach, and they degrade the blood and turn it to black. So black road tar-like bowel movements are a worrisome sign. People also with ulcer disease have tarry stools.
That's right. Another sign, I believe, is like early satiety.
So that's a fancy word, Rob.
Right?
What is satiety? What does early satiety mean?
So when you eat, then maybe a few bites into your meal, you'll feel full and you won't want to eat.
Why? Why do you think that is?
I'm not too sure.
Well, think about it. Your stomach is a container, right?
Yeah.
So you put food in your mouth, you chew it, it goes down your esophagus, it ends up in your stomach, and there it's exposed to all these juices, and it gets churned, and there's enzymes to break down the food so you can digest it through your intestine and colon, right?
Right.
So you got all these juices, but you got this container, it's a limited size. And if that container, let's say, is half filled with cancer, as soon as you take a couple of bites, you're going to feel full up.
Yeah, that's right.
So early satiety. Early satiety means that, you take a few bites and you're full up. It's a worrisome sign. So if you have early satiety, call us, 212 Choices, and we can help you out. So it's a worrisome sign. Get worked up. So, you got bleeding, you've got early satiety, you've got vague pain. Sometimes people have pain under their breastbone or in their left upper quadrant of their stomach. They should get worked up. And the best workup is probably endoscopy, where you look into the stomach, you can see what's there, and take a biopsy if there's something suspicious. Mm-hmm. And if you find it early again, the chance of cure is pretty substantial. And this article is talking about even if you have metastasis, you can live twice as long if you use good treatment.
Yeah.
And don't think that only chemo is the only treatment, because it is not. There's other treatments out there.
You told me to remind you about a patient to tell me who was in a hospice.
Oh, yeah.
Yeah.
I think we started talking about this patient last week. This woman came. So normally when you go to hospice, what does it mean?
So it basically means that you're assumed to be at the end of your life, and you just are going to die comfortably. Yeah, you get to try to die comfortably. And even there's radio commercials for hospice in New York. They're all over the place. Right.
So we had this woman. There was a woman in a hospice, in a big hospice that's famous in New York. And she was there waiting to die. She had massive skin cancers, one on the right cheek and one on the left cheek.
Okay.
And a dermatologist who I've known for 20 years, although I haven't seen him probably for 15 years, a very fine gourmet dermatologist, went on rounds just to see interesting cases in the hospice. And he saw this woman, and he was shocked that she was on hospice because of skin cancer, waiting to die. And he told the staff, I know who can probably treat this woman. And he called me last summer, maybe in May or June, and he said, Gil, can you take on this case? And he emailed me photographs of her cancer. It was massive cancers, like a big fist of cancer in the right cheek, going to the eye, the ear, and the same on the left. And she came to us with her two nieces who are really devoted to her. Mm-hmm. She's also Irish heritage, so it's kind of tells you the risk factor. And we treated the right cheek in June and July, 5 treatments. So it was really easy for the patient, 5 treatments only.
Okay.
And then she wanted to go on vacation. So she's already doing better. The cancer's going away. She's going on vacation. So imagine someone who's on the hospice, gets out of the hospice, and she's going. And we treated her. The cancer on the right side's going away. I think we have, how many minutes do we have? 30 seconds. So we'll tell you more about the other cheek, but she's out of the hospice. She's doing well. The cancer's going in remission. And thank God for that doctor. Thank God for her nieces. And thank God that she came to us. So if you have questions during the week, if you want the free package of information, DVD, or just questions, call us at 212-CHOICES. 212-CHOICES. That's 212-246-4237. 212-246-4237. Rob, thank you for coming. I hope you have a great week. And to all listeners, have a great week.
Have questions before next week's show or want a free informative booklet and DVD, just contact Dr. Lederman at 212-CHOICES. That's 212-246-4237. That's 212-246-4237. Till next week.
You've been listening to a podcast from News Talk Radio 710 WOR.